Test 1 2 1 2. Testing 1 2. Testing 1 2. All right. Thought we'd go ahead and get started. My name is Dave Lederer. I'm a pulmonologist from New York, which you can probably tell. And I'm here to talk to you today about interstitial lung disease, which I know will be a little bit unfamiliar to some of you, so I really am going to kind of start at the basics and try to reinforce why I think this is such an important disease. My disclosures are there in the bottom of the slide. I do some consulting work for pharmaceutical companies and diagnostic companies who are in the field of interstitial lung disease and pulmonary fibrosis. On your desk there, you do have a pre-activity survey that we'd like you to fill out. The slide deck is available to you online. You have that information there in front of you. And this educational event is supported by Boehringer Ingelheim, which I don't do any consulting for currently. So we have 4 learning objectives, and they are to review interstitial lung disease, what it is, how we diagnose it and classify it, talk about some of the recent advances in diagnosis and very importantly in treatment, and then talk a little bit about comorbidities. And if you only remember one thing, it would be great if you can remember this slide, which is going to come back at the very end. It's also my very last slide. And so some of it doesn't make sense right now, but by the end of the talk, it will make sense. So for those of you who take care of any patients with chronic lung disease, COPD, cystic fibrosis, pulmonary fibrosis or interstitial lung disease is probably less common than the COPD patients you see. But I will bet that some of your folks that you take care of who are labeled as COPD actually have this disease. So the first thing is crackles. If you hear crackles on exam, I want you to think about interstitial lung disease as a possible diagnosis on your differential. We'll talk about that. HRCT stands for high resolution CAT scan or CT scan of the chest. And I'm going to talk about what those numbers and words mean. And also you're going to see how important it is to talk to your patients. I know you guys know that. But how important it is to do a good history and physical exam and get some serologic testing before you proceed with something like a biopsy. 3 or 4 different diagnoses make up most of your patients, and I'll talk about that. And oxygen and pulmonary rehabilitation are critical components of care. Okay, so kind of started where I ended, where I'm going to end. But let me start now at the beginning, which is interstitial lung disease, which I know is not something most of you think about. Pardon me, and for some of you, this may be the first time you've heard that term, and that's okay. So this is a family, or these are a family of over 100 different diseases that affect the lungs, and it's not COPD or emphysema or asthma or even cystic fibrosis. This is a completely different family of lung diseases that are non-infectious and are not malignant, they're not cancer, and they're all characterized by inflammation or scarring in the alveoli, so on the walls of the air sacs or the interstitium. And some of them that you may have heard of include sarcoidosis, idiopathic pulmonary fibrosis, and then folks who have things like rheumatoid arthritis or scleroderma who get lung disease. This is what they get often. So previously considered to be a rare disease, nowadays recognizing more and more that this is a disease that's more prevalent. And these diseases can be confusing. And if you've been through either a class or a lecture like this where people talk about these diseases, there's all these different diseases and they kind of get mixed up and it's not clear. So I'm going to try to clarify all of that for you. And we do have limited treatments, but I will show you that we now have some newer treatments in the past few years that work well. So this is what people get caught up on. They get caught up on the classification scheme because it'd be great. Did my sound go out? Or you can hear me okay? Okay. It would be great if we just had one name for all of these diseases. Like we have one name for COPD, but it's actually a bunch of different types of diseases. But here, we really try to dig down in the nitty-gritty and classify this further. So I said it's inflammation and scarring in the walls of the alveoli. Pardon me, but we further classify that into diseases of known cause, which are there on the left, diseases of unknown cause, which we classify as idiopathic interstitial pneumonias. And you can see a list of them, and I think that's the list that scares people off. Then sarcoidosis, which has granulomas and is kind of its own entity. And then I'm not going to talk about the probably 89 other very, very rare interstitial lung diseases. I'm not going to talk about that. What I do want to talk about is really that column on the left, which are diseases of known cause. So when a patient shows up with interstitial lung disease, I'm going to show you this when I show you a CAT scan. We see it on the CAT scan, and the next step is to figure out if they have a disease of known cause or association by looking for medications that could have done it, like chemotherapy, radiation therapy to the chest, autoimmune conditions like rheumatoid arthritis and scleroderma, which we can often sort out by asking the patient about joint and skin symptoms, do serologic testing, do a good physical exam. Hypersensitivity pneumonitis is due to exposure to mold and birds, believe it or not, indoor birds. So people who've had mold in their home, who have pulmonary fibrosis, probably have this hypersensitivity pneumonitis condition. A lot of people have mold in their home. Most of them never develop anything like this, but a small percentage will, and then they'll develop not just inflammation but scarring. And I've had a lot of patients with this condition who pass away because they had mold in their home, kind of a preventable thing. And then pneumoconioses are occupational lung diseases like asbestosis and silicosis, and black lung, which is coal workers' disease. So asking patients about mold in their home, dampness in the home, water damage in the home, and a good occupational history can really help sort out which kind of interstitial lung disease they have. And one thing that I see in my practice currently is 100% interstitial lung disease, is that folks usually show up years after the onset of symptoms. And so they may develop the common symptoms, which are exertional breathlessness and dry, non-productive cough, chronic, that's not improving with symptomatic therapy. And initially, folks are usually diagnosed with COPD or heart failure, or asthma, or just being overweight or out of shape. And then eventually it turns out, oh, you have scar tissue filling up your lungs, and it's quite serious. So on average, about 2-year delay from the onset of symptoms until they show up with disease. So giving you a little bit of background and context, but it's much easier to understand this condition with a case. So this is a 67-year-old man, and he presents with 4 years of persistent dry cough and 1 year of exertional dyspnea. He was recently seen in the ED for dyspnea and cough, fever, and treated with antibiotics for walking pneumonia. And the fever went away, but he's still coughing and short of breath. There's no hemoptysis or wheeze. He says this dyspnea that he's had for a year has really gotten worse over the past 6 months. And no other current symptoms. So again, the fever went away, URI symptoms went away. There's no chest pain or chest pressure, orthopnea, PND, pedal edema, weight loss. And on exam, his vitals are normal, and even his oxygen saturation is normal. So this is someone with lung disease. It will turn out to have lung disease, but their saturation is 98%, and that's not uncommon that we'll see a normal resting saturation. But if you take a patient like this and walk them around, you're going to see that their sats plummet, and that's a good clue that there's interstitial disease present. On exam, the only thing we hear are inspiratory crackles. There's no wheezes, no rhonchi, no decreased breath sounds. And so with that very little bit of history and physical, you could immediately develop a very broad differential diagnosis, both for cough on the left and for exertional dyspnea on the right. And of course, ILD, the disease I'm talking about, no way that's not going to be at the top of a differential at this point. But my hope is that it's on your differential at some point. So when you're approaching these patients with chronic cough that's not responding to therapy, chronic exertional dyspnea, not completely explained by other factors like heart failure, who have persistent crackles on exam, that's the key physical finding, that ILD will be nestled, you can see ILD in both columns, that it'll be nestled into your differential. As I mentioned, sorry about that typo, that value there, but there's estimated to be about 200,000 people in the US with pulmonary fibrosis of some kind. And here we've used the abbreviation IPF, which is idiopathic pulmonary fibrosis, which is one of the interstitial diseases. And of course, those folks are much less common than, say, having heart failure or COPD, where there are many more people. So your patients with dyspnea, again, more likely to have heart failure, COPD, and asthma rather than IPF, but important to keep on the differential. So I'm going to try to have you guys raise your hands with a yes, no, I'd do that, I wouldn't do that. So feel free to, I don't know your names, so I'm not, it's okay to say yes or no. So what else would you do? If 67-year-old man, exertional dyspnea, cough and crackles, what other things would you think about doing? So who would do some more history? I think we'd all say yes, right? We always want more information from the patient. How about pulmonary function testing in someone with exertional dyspnea? For sure. I think everyone should get spirometry if they have shortness of breath and maybe even diffusing capacity if you can. Chest x-ray in someone with shortness of breath, I agree. Echocardiogram, all hands go up, right? Short of breath, everyone gets an echo. Serologic testing sounds premature. We haven't even talked about that. How about a high-resolution CT scan of the chest to look for interstitial lung disease? Maybe also premature. I don't think it's unreasonable to jump to it, but certainly you could do the other workup first. And I think we'd all agree what would we even biopsy? Why is it even on this list? So way too premature. So we get a little bit more history. Does have a history of gastroesophageal reflux disease. No joint pain, no muscle pain, skin changes, dry eyes, dry mouth, ray nose, right? Nothing that would indicate autoimmune disease, which I mentioned. He was in Vietnam. The timing's a little bit off maybe, but exposure to Agent Orange, and I'll tell you, Agent Orange has not been implicated in this disease at all. But he did remodel his home 30 years ago, and that home was subsequently condemned due to mold. This is based on a real case. And for the past 4 years has worked in airline industry with potential exposure to aerosolized lubricants. And we do know that chemicals like isothionates can cause occupational asthma, but also can cause hypersensitivity pneumonitis. So we get concerned about the mold. I mentioned mold as a cause of fibrosis, and he is a former smoker. So here's some more objective testing. We get pulmonary function testing, and his FEV1 is 89% of predicted, and generally speaking, over 80% we'd call normal. So it's a normal FEV1, right? And that's the amount of gas that you can blow out after maximal inhalation, blowing out as hard and fast as you can, how much air comes out in the first second. So he had 2.74 liters, or about 89% of expected. And his forced vital capacity was 3.4 liters, which is a measure of how much air your lungs can hold. So that was 79% predicted, so right on the borderline of normal and abnormal. And folks who have this inflammation or scarring in their lungs get stiff, so their lung volumes go down. And FVC, which is measured on spirometry, is the most useful test to monitor disease progression. As scar tissue builds up, FVC goes down, and his lung volumes go down because the lungs are stiffer. His FEV1 FVC ratio is 81%, which is normal. If it was below 70%, we'd be worried about COPD, but a ratio of 81% pretty much excludes COPD. And his diffusing capacity is 68% predicted, and that's a measure of how easy it is for oxygen, or in this case carbon monoxide, to get into the bloodstream. And that's reduced in lots of different lung diseases, including COPD. So isn't not specific for interstitial disease, but certainly most of the time these folks have a low DLCO. Echo is normal, so no diastolic dysfunction. The left atrium's normal, the RV's normal, LV function and size and wall thickness. And here on the right is a chest x-ray. I don't know how well it projects, but the lungs don't look normal. They should be much darker than this, and there are lots of white linear markings. Definitely shows up better over here, but both lungs have what we call interstitial changes or interstitial markings, again, in both lung fields. That could be pulmonary edema, possible. Person has crackles, but echo's normal, and he has no edema on exam, so it seems unlikely. So this is kind of an important slide. So here, this is a patient with dyspnea or cough, and then have any of these other objective findings. So crackles on exam that aren't going away. You tried to diurese them, and their echo's normal. Hey, they still have crackles. Maybe it's interstitial lung disease. I mentioned desaturation during exertion, so just walking them around can be really helpful. Low FVC and spirometry, low DLCO, and then abnormal chest x-ray. So any of these things, symptoms combined with any one of these other findings, should really raise your suspicion for interstitial lung disease. So at this point, if you think someone has ILD, which of these, and you can only choose one, which of these is probably the best next step? Would it be looking for autoimmune disease by checking serologies like an ANA or rheumatoid factor? Anyone favor that? How about a high-resolution CT scan of the chest to look for interstitial lung disease visually? A few people. And how about immediately moving to a surgical biopsy of the lung? A few people. So my preference is always to do a high-res CT before the biopsy because it can give you new information and establish that ILD is present. And if you do decide the biopsy, then it can tell you kind of what areas of the lung to either sample during biopsy or to avoid. So CAT scans, of course, give us an image of the lungs, and we can look both axially, coronally, and sagittally at the lungs. An important aspect of a high-resolution CT scan is that the images are reconstructed using what's called a high kernel, and that word is all the way down here. In the second to last bullet, it says high kernel reconstruction. So that's a little bit different than our standard CAT scan. Standard CAT scans accentuate the edges of nodules, lymph nodes, tumors, and masses, whereas a high kernel reconstruction emphasizes the detailed structure of the lung, which will tell us all about the inflammation and scar tissue that might be there. We also typically do inspiratory imaging and expiratory imaging. So key thing about high-res CT is that high kernel, inspiratory and expiratory, and up on top you can see approximately 1 millimeter slice thickness, really important. So thin high kernel reconstructions is what a high-res CT is. And here's a good example of the difference between a standard CAT scan. It's actually pretty, I mean, we don't ever really do 10 millimeter anymore. We usually do 5 millimeter. But you can see here on the left, 10 millimeter with the standard reconstruction looks pretty blurry. But then when you take the same patient and do a high resolution reconstruction and do thin imaging, we get a lot more detail, and we can really distinguish now some of this hazy inflammatory change from more reticular fibrotic change and some traction bronchiectasis. So back to our case, remember our 67-year-old man, exertional dyspnea, cough, crackles, low DLCO, borderline FVC, abnormal X-ray, right? Normal echo, gets a high-resolution CT scan. And here you can see in these 4 images a lot of normal dark parenchyma, right? Normal healthy lung is black or nearly black with these nice white blood vessels coursing through them. But around the periphery of the lung, you can see, and sorry I don't have an arrow here, but you can see extra white lines along the periphery of the lung, particularly in the bottom 2 images, which we call reticulation. And reticulation on a CAT scan, if you see a CAT scan report says there's reticulation, that's the radiologist telling you that there's fibrosis. And if there's fibrosis, you should be concerned about interstitial lung disease. So when we see this reticulation on a CAT scan, one of the very first things I do as a pulmonologist, and your radiologist will also do this, is begin to sort out whether or not it falls into what we call a UIP, or usual interstitial pneumonia pattern. The UIP pattern is a visual pattern on a CAT scan or even on a biopsy, but in this case we're talking about a CAT scan. And it really is, if there's reticulation, where is it? And if it's in the lower lobes and it's along the periphery or subpleural, then we typically call it UIP as long as there's also a finding of honeycombing. And honeycombing are these thick-walled linear cysts. Sorry, I'll show it to you in a moment. But honeycombing are thick-walled linear cysts around the edge of the lung. So if we see that fibrosis or reticulation, lower lung zones, peripheral, with honeycombing, we call it a UIP pattern. And that pattern is really important because if we find that pattern and we've done a good history and physical and we can't figure out why they have interstitial lung disease, at that point we would render a diagnosis of idiopathic pulmonary fibrosis or IPF. And making that diagnosis is important because number one, they have a poor prognosis and need to be referred for lung transplantation. And number two is we do have some FDA-approved therapies to treat IPF. There are other patterns like a possible UIP pattern, inconsistent patterns. I won't go into the details there, but anything other than a UIP pattern really ends up having the pulmonologist and the radiologist communicate, decide if they can come up with a diagnosis when they combine the history, the physical, and the CAT scan appearance. And I would say about 50% of the time we can do that. And then other times we're left without an answer, and that's when we would consider a surgical lung biopsy. So just summarizing what we have so far, I'm going to add a little bit more information. Remember, 67-year-old man, dyspnea, cough, crackles, borderline reduction in FVC and DLCO, normal echo, very abnormal chest x-ray. His CAT scan is a UIP pattern almost, because he has no honeycombing. Remember I just said reticulation. So I'll say possible, kind of equivocate a little bit. And we sent some autoimmune serologies like an anti-nuclear antibody, rheumatoid factor, anti-CCP, everything was unremarkable. So it didn't seem like there's autoimmune disease. So this multidisciplinary evaluation or multidisciplinary discussion is what I was referring to when the pulmonologists and radiologists get together. Each of us alone, and this has been looked at even in research studies, so when a pulmonologist is trying to figure it out for an ILD patient, which kind of ILD this is, it can be very challenging. The radiologist alone doesn't have the clinical information, but when you put two heads together, you can often get a better answer. So it turns out that when you put the pulmonologist and the radiologist together, and if you have a biopsy, then also trying to loop the pathologist in, the diagnoses become more accurate, and at least people tend to agree more when you have them communicate. So for many patients, that's an important part of the diagnosis. As I said, if you can't figure it out with the pulmonologist and radiologist discussing it, and a biopsy in some cases is really important. So in our patient, I've highlighted in yellow here what the differential includes. So we've kind of ruled out a bunch of things. So there were no medications like chemotherapy, amiodarone, nitrofurantoin, no medications that we talked about that could have caused this man's fibrosis. He never had any cancer, radiation therapy, so that's off the table. There's no signs or symptoms of autoimmune disease. Serologies were negative, so that connective tissue disease, vasculitis stuff is off the table. And we don't really think that this exposure in the airline industry to this exposure was relevant. So pneumoconioses are also off the table. However, hypersensitivity pneumonitis with fibrosis on CAT scan and potential mold exposure in the past has to be kept under differential. And then that second column, these are all the idiopathic diseases. Those also should be on the differential. And most important would be the first two. First one is idiopathic pulmonary fibrosis that I mentioned. I'm going to talk about it a little bit. And the other is a disease called idiopathic nonspecific interstitial pneumonia, which is really a visual pattern on a lung biopsy. It's very kind of homogeneous fibrosis throughout the lungs, often seen in folks who either have an autoimmune disease or who might have just a positive ANA but don't turn out to have, say, scleroderma or something. So again, I'm not going to go into all the detail about all the different idiopathic interstitial pneumonias. It just ends up being confusing. The important thing is do a good history and physical, get serologic testing, figure out the things on the left-hand side before you jump into a biopsy to see if it's anything on that second column. So IPF, I'm going to shift and speak about now this one common type of interstitial lung disease called idiopathic pulmonary fibrosis, or IPF. So idiopathic, of course, means of unknown cause. So one of the first things is, as I said, do a history and physical. I can't overemphasize how important it is, but do a history and physical to exclude those known causes. So once we've done that, if there's a UIP pattern, which is, remember, that peripheral fibrosis or reticulation on the CAT scan, mostly in the lower lobes with advanced honeycomb change, that's a UIP pattern, you're done. You've made a diagnosis of IPF. So that's the easiest way. Exclude known causes, have a UIP pattern on the CAT scan. However, when there's no UIP pattern on the CAT scan and there's uncertainty about what it is, then again, a surgical lung biopsy, thoracoscopically done, can be quite helpful. So who would vote to do a surgical lung biopsy in this patient? Remember, I equivocated on possible UIP, I'm not certain. We have a broad differential. So surgical lung biopsy seem reasonable? The answer is probably yes, because we do have uncertainty. And if the patient's an appropriate candidate, right, and that's a really important part of it, you don't want to send everyone for a biopsy because some people are actually quite a few people are going to be at high risk for complications. In one large study looking at surgical lung biopsies performed in the United States, the mortality risk was 1.5%. That was for elective procedures. So I do refer some patients for a surgical lung biopsy, but I have many more patients who I say, you know what, I'm not certain. It could be one of these 2 or 3 different ILDs, but you in particular are at high risk for complications, and that would generally be things like lots of comorbidities, older frail patients, or people with quite advanced pulmonary fibrosis. I don't biopsy those folks. And I think with careful selection, I haven't really seen any complications, at least in my practice. The other thing is I only biopsy people if I think the result is going to help change therapy, because I don't really care so much about putting someone in a box. It's like, this is the name of your disease. But I can say you have a fibrotic interstitial lung disease. How am I going to treat you? Well, if I think the biopsy findings will inform treatment, then I often will refer them. But again, I will always do my best to try to make a diagnosis without a biopsy. So I've referred to this pattern, this UIP, or usual interstitial pneumonia pattern, as something we see on a CAT scan. And when we see it on a CAT scan, it's helpful because it means that if we did a biopsy, again, we usually don't biopsy those folks, but if we had done a biopsy, it's very likely that we would have seen a usual interstitial pneumonia pattern on the biopsy. So we use the same terminology for the CAT scan findings and for the biopsy findings, and both indicate a diagnosis of IPF. So in this man, who didn't have a lot of comorbidities, had more mild disease, didn't quite have that UIP pattern, was almost there as a possible pattern, he underwent a surgical lung biopsy, and it did show a UIP pattern, and therefore, based on the biopsy with no known cause, UIP pattern would give us a diagnosis of IPF. Now, I'm going to show you, here's the histology, the staining pink and purple because of H&E staining. On the left is a low power view, and those white spaces are air spaces or alveoli. And the very dense pink spaces are scar tissue. Those dense pink spaces should have normal alveoli. So we see this patchy pink stuff, that's patchy fibrosis, which is the classic finding of UIP. So it's only in some areas and not all areas. And then on the right, it's hard to see there, but at high power, there's a collection of fibroblasts, which are these pale staining material. I know you can't see it, and I know I'm pointing, I apologize. But when you see the pathology report and it says patchy fibrosis and fibroblasts or fibroblastic foci, that's a big clue that it's a usual interstitial pneumonia pattern. So now I've mentioned IPF or idiopathic pulmonary fibrosis many times. It is the most common of the idiopathic interstitial diseases, one of the more common diseases I see in my practice, along with autoimmune ILDs and hypersensitivity pneumonitis. So as I mentioned, patchy fibrosis, you'll hear the term peripheral lobular or paraseptal fibrosis. It is a disease of older adults, very common before the age of 50, and in fact, even people in their 50s who have fibrotic disease usually don't have this. It's really in folks over 60, 65 who tend to have it. And for those who suffer from the disease, it is really a terrible disease. Very disabling exertional dyspnea and cough, at least in the more moderate to advanced stages. Severe functional impairment. Folks can't engage in their daily activities. They can't go engage in activities with their grandkids or go shopping, or they become very, very limited by their symptoms, and many will need to use supplemental oxygen, particularly while they're active out of doors. And the median survival time is only about 4 years. And most people with this disease will die from this disease, will die from IPF and respiratory failure, either acute or chronic respiratory failure. And until just a few years ago, there wasn't really much to do for these folks. Some people would give them corticosteroids. Lung transplantation is certainly an option, but we do have a couple of FDA-approved therapies. So with that in mind, what are some of the management steps that we might think about right now? So who would consider putting this patient on some medication to treat their lung disease? Probably not a bad idea if we have something, and we do. We have a couple of drugs I'll show you. We might start oxygen, but we'd have to assess whether or not they need it. Right? We use the same criteria that we use for COPD, if they desaturate to 88% or less. You can always refer to an ILD center. Dr. D'Andrade at UAB has a really nice ILD program. You can refer for lung transplantation, and we usually do that as early in the disease process as we can. At least we refer early on. It can take a few years to get on the list and then wait for a lung. They usually don't get transplanted until the very severe stages of the disease. Sleep study, a lot of these patients have sleep apnea, but without symptoms. We didn't talk about snoring or anything, so I'm not sure I do that. How many people here are familiar with pulmonary rehabilitation? So this is a structured exercise program for outpatients with lung disease. Most people in pulmonary rehab have COPD, but folks with pulmonary fibrosis and cystic fibrosis can also participate in pulmonary rehab, and it can be really beneficial for patients with different forms of ILD, particularly if they need oxygen. They can learn how to use oxygen, how to exercise with oxygen. And then if possible, we always try to get these patients in clinical trials of experimental therapies, of which there are quite a few right now. So I've kind of talked about this quite a bit, about management. Again, I'll talk about the drugs in a moment, but some of the important things to think about with these patients are making sure you're getting oxygen assessment. So we do that either using a 6-minute walk test to see if they desaturate, and if they do, put them on oxygen, or repeat the walk test to see how much oxygen they need to maintain their SATs up in the low 90s, mid 90s. We also, at our center, we do 6-minute walk testing, but we measure oxygen requirements using a treadmill. We do a treadmill titration, which works really well, and we try to get people to push themselves just to whatever their usual daily activities are. And if they desaturate, we'll put them on oxygen and show them how much more they can do with oxygen, and how their symptoms are partially alleviated and how they're more functional. Again, if they need oxygen. People in the mild stages of the disease generally don't need oxygen. I'm just going to keep this out here for time purposes. So the top of the slide said there's no universal treatment strategy, and this is right. All patients are different. Those with more fibrotic disease or IPF would be considered for antifibrotic therapies that I'll show you. Those with more inflammatory diseases might be considered for immunosuppressive agents. And although there's no FDA-approved drugs for inflammatory disease, we do use off-label drugs like prednisone and mycophenolate mofetil and azathioprine to treat those. They're FDA-approved for other indications, but used very commonly to treat inflammatory interstitial disease. I don't know if you guys have a Better Breathers Club here, you know, a support group for people with COPD. There are also pulmonary fibrosis support groups around the country. And the Pulmonary Fibrosis Foundation has a website that has all the support groups that they maintain. I'll talk a little bit about guidelines, but this is a challenging disease, both to recognize and diagnose. And again, I know a lot of you haven't heard about this disease before, and that's a testament to how uncommon it is and how hard it is to recognize, because it's kind of not on everyone's radar, even though we end up finding a lot of it. I've gone through this. I do want to mention comorbidities a little bit. These folks often are older and often do have comorbidities like coronary disease. Some can develop pulmonary hypertension on top of their interstitial lung disease. The pulmonary hypertension usually is not severe, usually doesn't require vasodilator therapy, but often requires oxygen, occasionally would require diuresis or digoxin or something like that. They also are, as I mentioned, at risk for obstructive sleep apnea. A lot of them also have GERD, which some people theorize might contribute to fibrosis through microaspiration. I don't really believe that theory, but it's, I guess, a possibility. And they are also at increased risk for lung cancer, so if they meet the USPSTF criteria for lung cancer screening, they could be considered for annual CAT scan screening as well. I follow my patients with pulmonary fibrosis usually about every 3 months and do spirometry and DLCO to monitor progression. And some obvious things that I've mentioned, or one includes, of course, smoking cessation for active smokers, but supplemental oxygen when indicated. I have a lot of my patients who monitor their saturations at home, and they'll increase their oxygen flow rate to keep their SATs up in a normal or low normal range. Pulmonary rehab and transplant we mentioned, simple things like age-appropriate vaccination of influenza, Prevnar 13, et cetera, is really important. Clinical trials, I mentioned some of these things. And here are those, I jumped ahead, but here are the comorbidities that can be impactful in their lives. Most people, again, with this disease will die from pulmonary fibrosis, but 30 to 40% will not. 30 to 40% will die from lung cancer or heart disease and other things, so we do try to keep that in mind. All right, so now we're going to move to some of the tricky stuff, things that I'm pretty confident most of you don't know, which is good because it gives me an opportunity to teach you something. Before I ask you this question, let me ask, how many people have heard the word pirfenidone, that first option there? How many people have heard of that? That's great, because now I'm going to be able to teach you something you don't know that you might be able to implement in practice, or at least if you encounter patients with pulmonary fibrosis, understand why they're on these drugs or decide to prescribe them yourself. Okay, so I will tell you, since you guys don't know what pirfenidone is, I will tell you that pirfenidone and nintedanib, these first two on the list here, are FDA approved to treat idiopathic pulmonary fibrosis. We call them antifibrotics, but I'm going to explain what that means. Imatinib is not. It's a tyrosine kinase inhibitor that's used to treat chronic myelogenous leukemia. It actually has been studied in IPF. It doesn't work. And sildenafil is used to treat pulmonary hypertension in TID dosing, and it's also not indicated for this, indicated for pulmonary hypertension. So let me now talk about these two drugs. This is cool because you guys don't know about them, so I can educate you. So both of these drugs were approved by the FDA to treat idiopathic pulmonary fibrosis, this one kind of disease with a UIP pattern. Approved in October 2014, so we're about 3.5 years, coming up on 4 years later this year, that we've been using them in the US. It turns out pirfenidone, however, was approved in Japan in 2008, so there's about 10 years of worldwide experience. And pirfenidone was also approved in Canada, India, and Europe long before it was approved in the US. So again, a lot of worldwide experience. And nintedanib, we have a little less experience, but also approved in October 2014 and later approved in the UK and Europe. So what are these? These are orally available medications. Pirfenidone is a tiny little non-peptide molecule that's been studied in animal studies and in basic science lab research for many years, and it's known to have effects on fibroblasts. Fibroblasts are the cells in the lung that make scar tissue or collagen. And it inhibits a lot of growth factors and inflammatory cytokines, and slows down the deposition of collagen in the lung. So it sounds really good, but it took a whole lot of clinical trials to prove that it actually worked in pulmonary fibrosis. So lots of different ways that it can work. Nintedanib inhibits enzymes called tyrosine kinases, and all of these tyrosine kinases are downstream for what we call growth factors, and they're growth factor receptors on fibroblasts, so it's the same cell type. So in things like vascular endothelial growth factor receptor, or platelet-derived growth factor receptor, or fibroblast growth factor receptor, on the surfaces of fibroblasts get stimulated, meaning it'll tell the fibroblasts to grow and secrete collagen and scar tissue into the environment. Nintedanib gets in there and blocks those signals. It can have some other effects too, including on lung cancer. So I want to give you a little bit of detail about these drugs and the evidence that they work, and then show you what the current guidelines recommend. So Impulsus is the name of two clinical trials, Impulsus 1, Impulsus 2, that were really identical trials that studied nintedanib. And you can see nintedanib at the bottom there. So, and I apologize, you're not going to have to say nintedanib 10 times fast, but I say it a lot, so I've gotten better at it. It's hard to say. But Impulsus were, again, two studies. Two studies that enrolled over 1,000 patients with idiopathic pulmonary fibrosis, and they were randomized to receive either nintedanib or placebo in a 3-to-2 fashion. So double-blind, placebo-controlled clinical trial, and the primary outcome was the change in lung function as measured by spirometry, by FVC that I mentioned before, over 1 year. So typically in IPF, lung function declines about 200 cc's or 200 mLs over the course of a year. In IPF, healthy people lose only about 50 cc's per year. We all, at least adults, after peak lung function, we all slowly lose some lung function over time. So what was shown in both of these studies is that the lung function decline was slower in the people who were receiving treatment with nintedanib compared to people who were treated with placebo. So on the left, the y-axis there is the change in lung function over a year. So going down more negative is bad. So losing 200 cc's is bad. So in the gray bar, which is the second bar, is people who got placebo, and they dropped pardon me, by 239.9 mLs on average, whereas people who got nintedanib only dropped by 114.7 mLs. So cutting the reduction in about half, right? So from about 200 to about 100. So most people in the field that I work in will say, yeah, nintedanib slows the decline in lung function by about half. And they showed the same thing in Impulsus 2, which is on the right there. So two different studies showing the same thing. This is the primary outcome. And this is good. Before these studies, there was nothing that was ever shown to slow the progression of the disease. So this was very encouraging. It was actually published in May of 2014, so just about 4 years ago. So this is a good thing. Now, what I'd really like to see is the lung function going up. So these drugs don't actually make people better, and that's a problem with them, is that they don't improve things. They don't increase lung function. They don't decrease oxygen requirements. They don't relieve symptoms. But in the long run, as people progress, on or off of treatment, they'll progress. They progress more slowly on treatment. And that's a complex discussion with the patient to have, because I then say, well, I'm going to give you a medication that, in this case, nintedanib, 60% of people have some form of diarrhea, ranging from very mild to very severe, often manageable with loperamide and dose reductions and things. But I want you to take a medication that's going to interfere with your GI tract, and it's not going to help your breathing. At least today, it's not going to help your breathing. But if you stay on it and stick with it for a year, 2 years, it can help slow down your disease progression. And some patients really want that. They say, oh, great, you know, I want anything I can do. This is a serious disease, so I'll deal with a little bit of GI side effects. And other people say, I don't want that. And that's okay, right? And this treatment may be right for some and not right for others. As I mentioned, approved 3.5 years ago. We have seen now, not in my practice, but it's been reported, drug-induced liver injury has actually been reported now with this. We've always monitored LFTs. Some people have elevated LFTs, and we give them a holiday off the drug, and it resolves. But now real liver disease has been reported in at least one case of nintedanib. So it is very important to monitor liver function tests. If you prescribe this, it's taken 150 milligrams twice a day with food. And again, there are ways to manage side effects that ILD docs or pulmonologists deal with all the time. And that drug is being used. I prescribe it. I see lots of patients who are on it. I'm going to switch to that other drug, pirfenidone, that small molecule that works in lots of different ways in the fibroblasts. So pirfenidone turns out in clinical trials, same exact type of effect. It slows down the rate of progression by half. So both drugs really seem to have the same efficacy when compared to placebo. They've never been really compared head-to-head. But here it's presented in a different way, but you can see that primary endpoint on the right, that's at 52 weeks. The percentage of people who either had worsened lung function or died during the study was about 30% got sicker or died during the study in the placebo group versus about 15% in the treatment group. So again, about a 50% relative reduction. This was the primary outcome. Based on this study and a couple other studies of this drug, as well as the studies of nintedanib, both drugs, again, were approved by the FDA. Major side effect, so here I have to tell you nausea is the most common, but the truth is, in my practice, it's loss of appetite. Everyone, to some degree, has a poor appetite once they go on this drug. And it can be a little bit hard to take, both drugs, right? One has diarrhea, this one has loss of appetite and nausea. So working with patients to try to attenuate these side effects is really important. And setting expectations with the patient, both about efficacy and expected side effects. Rash is really a rash, photosensitivity reaction that could be dealt with pretty easily. Liver function tests need to be monitored. No one's had drug-induced liver injury, at least hasn't been reported, but abnormal liver function tests are common. It is taken in a dose titration way. Since it can cause loss of appetite and nausea, we slowly increase the dose over a few weeks. And it is taken 3 times a day, so it's a little bit less convenient. Okay, so giving you, I mean, there's a lot more data on those drugs, including respiratory outcomes, mortality, and all of that, but I've just focused on the primary outcomes here. So there have been now, 3 years ago, these treatment guidelines were published from a few professional medical societies. ATS is the American Thoracic Society, which is one of the 2 main pulmonary professional medical societies. And in between 2011, which was the first treatment guidelines, and 2015, you can combine those guidelines, which I've done here. So there are strong recommendations for oxygen and lung transplant when needed, and then what we call conditional recommendations for pirfenidone, nintedanib, antacid therapy, which I'll come back to, and pulmonary rehab. So a couple of things. One is, what does conditional mean? Well, conditional means shared decision-making with the patient. So here's the benefit, here's the side effects, and you have a few options for these drugs. Is this something that you would be interested in taking now that you're educated about it? And like I said, some patients say absolutely I want it, and others say I don't want it. So it's a conditional recommendation, not a temporary recommendation. That doesn't mean temporary. It just means it'll be right for lots of your patients, but not for all of your patients. Antacid therapy. I have to mention antacid therapy. So I mentioned that GERD is very common in people with this type of pulmonary fibrosis, and there's a theory that maybe GERD and microaspiration could lead to fibrosis. Very controversial. And there are some studies out there, not high-quality studies, not clinical trials, a couple studies out there that suggest that people with pulmonary fibrosis who take antacids tend to do better in the long run than those who don't. There is a clinical trial that's been completed, hopefully will be announced next month when the ATS meeting occurs in San Diego, and we'll find out if treating GERD and IPF is actually a good thing or not. So I'll leave it at that. It is a little bit controversial. This slide is a little confusing. It's the recommendations against treatment for IPF, and we do have good evidence that prednisone increases mortality in IPF. Ambrisentan, which is a pulmonary hypertensive drug, worsens outcomes. Imatinib doesn't work. N-acetylcysteine orally doesn't work. Macitentan, bosentan, sildenafil in clinical trials don't work. The confusing thing is the first one, anticoagulation. So this is based on a clinical trial where they actually used warfarin to treat IPF, which is strange because it's not a thrombotic disease. But there was some basic science data suggesting coagulation cascade was involved. So it turns out, maybe not surprisingly, if you put people on anticoagulation when they don't need anticoagulation, they have worse outcomes. So we don't use anticoagulation to treat IPF, but on the other hand, if you have a patient who needs anticoagulation for AFib or VTE or something else, you should definitely anticoagulate them. So don't overinterpret that. I've already discussed shared decision-making, so I'll skip that. I do want to emphasize the importance of lung transplantation. This is really true across the board, not just pulmonary fibrosis, but COPD, cystic fibrosis, and pulmonary hypertension. All are indications for lung transplantation, and early referral for transplantation is much better than late referral. So I think, I don't know how many centers you have around here who do transplant. I know UAB does transplant. So early referral for transplant evaluation is really, really important. So back to our case, and this is a very typical outcome or management plan. So this is, remember, a 67-year-old man who we've now diagnosed with IPF. So we put him on therapy, and that could have been nintedanib or pirfenidone. And in my practice, usually it's a discussion with the patient. They end up having a preference for one or the other based on side effects usually. We did that oxygen titration study on a treadmill that I described, and it turns out he did need 2 liters to maintain his SATs up in the 90s. We also did a 6-minute walk test on the 2 liters, and his SAT went down to 90, which is okay. So we gave him 2 liters of oxygen with exertion. I also told him to use it with sleep, but of course I could have done nocturnal oximetry if I wanted. He got Pneumovax, he got Prevnar 13. We have a support group at our center. There are over 100 PF support groups around the country. We referred him for rehab and lung transplantation. That kind of plan is very typical in my practice, that we would do something exactly like that. So this is one of the first slides I showed you, most important things. So crackles, think ILD, crackles. High-res CT fin imaging with that high kernel reconstruction gives your radiologist the ability to identify ILD, but even more importantly, start to distinguish one type from another. Do not jump into a surgical biopsy. Get a history, physical, get to know your patient. You might be able to figure out if they have one of those diseases of known cause. And I actually didn't get into this, but most of your patients who have fibrosis on their CAT scan will have IPF, autoimmune disease like rheumatoid arthritis, this hypersensitivity pneumonitis disease. What's not listed here, the other one is sarcoidosis, although it usually is pretty obvious that they have sarcoid. And then again, oxygen and rehab are really the only things that help your patients feel better. The other stuff, medications are important, but these are the only things that make your patients feel better, and it's important to treat our patients. So I won't go through this slide, I'll leave it up there. I'm going to end now, and I'm happy to take any questions. Thank you so much. Questions? Yes, sir.
Do you ever have a return of ILD and transplant?
Good question. The question is, can the disease recur in a transplanted lung after a lung transplantation? The answer for IPF is we've never seen it, but for some other interstitial lung diseases, we have seen it, including sarcoidosis, desquamative interstitial pneumonia, lymphangioliomyomatosis, or LAM. So there's a handful of about 10 or 11 where it has come back. Sometimes it just comes back on a CAT scan or on the biopsy that, surveillance biopsy that we do. But sometimes it comes back and is enough to make them sick. Yeah, but it's not common. Other questions? All right, well, then I'll end. Thank you so much for your time.